Good morning, everyone, and welcome to this Thyro multidisciplinary seminar. I am really pleased to have our panel join us this morning. As you can see, this is an extremely international group, and Mike Tuttle will be taking care of running the panel discussion this morning, which is extremely popular tumor board session. And so with that, I'm going to let Mike I'll turn this over to Mike. And as always, we encourage all of our participants to send in their questions during the session, and we will do our very best to get to those before the end of the hour. So Mike.
Fantastic, Mark. Thanks very much, and welcome everybody this morning. I'm particularly interested, I think we've got some great cases this week that are just very practical things that we get asked about all the time, not the fancy molecular testing, not the out of control stuff, the real stuff we deal with every day. So what we'll do is we'll go around and we'll have folks introduce themselves to begin with. Dr. Rossleigh?
I'm a nuclear medicine physician. I work at Prince of Wales and Sydney Children's Hospital in Sydney.
Perfect. Dr. Alexander?
I'm Erik Alexander. I'm an endocrinologist at the Brigham and Women's Hospital in Boston.
Dr. Baloch?
Zubair Baloch. I'm a pathologist at University of Pennsylvania Medical Center in Philadelphia.
And Dr. Pasieka, who just stuck the landing. Unmute and tell us who you are, Janice.
Hi, Janice Pasieka, endocrine surgery at the University of Calgary.
Perfect. Fantastic. You've already met the good Dr. Erik. Dr. Pitoia, in my disclosure slide, I should admit that Dr. Pitoia and I have been friends for probably 20 years, long time together, working together, and he's done a tremendous job helping me understand that not everybody practices in a white ivory tower like I do, and helping me understand how guidelines and applications and stuff is different all over the United States, all over the world. So he's been one of the major influences on me to kind of help me think outside just the 17th floor of the Koch building on the Upper East Side of Manhattan, which I think has sort of improved my practice and the way I think about these things. Dr. Pitoia, introduce yourself, and then we'll let you get started with the first case.
Hello, good morning. My name is Fabian Pitoia, and I am an endocrinologist from the University of Buenos Aires Hospital de Clínicas.
Perfect. All right, let's go with the first case, Fabian.
So thank you for the invitation. And we are going to start with this first case, a female patient, a 38-year-old. In her first consultation that was in May 2017, she had a thyroid nodule, a hypoechoic thyroid nodule in the left lobe, measuring 7 × 5 × 5 millimeter with microcalcification. And at another center, a fine needle aspiration biopsy had been done, and a Bethesda Category VI papillary thyroid cancer was diagnosed at that moment. The patient underwent 3 previous consultations looking for the doctor who wanted to do an active surveillance. She had been reading about active surveillance, and she didn't want to get operated on. And the 3 previous consultations had offered total thyroidectomy. And so she read that we were doing this at the hospital, and she came to our hospital. It's very important to know that this patient had a past history of this same thyroid nodule with the same measurements 6 years before, with a normal TSH during all her follow-up. And at that time, no fine needle aspiration had been done. Nobody told the patient that she had a probably high risk patterns ultrasonographic thyroid nodule. And the patient did the following ultrasound 6 years later when she came to another center and fine needle aspiration biopsy was done.
Now, Dr. Alexander, last time I read the guidelines, American Thyroid Association guidelines, they said we don't even need to biopsy things less than a centimeter. Just between the few of us here, do you really do that? Do you tell a 38-year-old with a suspicious thyroid nodule not to biopsy it?
I do generally. I mean, you want to take individual, desires and I guess our own thoughts and risks into assessment. Often you're putting it into the bigger picture too, other comorbidities if someone's older, I don't know, whatever reason. But I think the data are pretty strong that, it all stemmed, if you remember back from the autopsy data decades ago, where if you really start to look at thyroids after someone's died of something else, you'll find micropapillaries all the time, maybe, I don't know, 20, 40%, something like that. So, and then the Japanese data has really taught us, if you look for the right lesions, even if we think they're really papillaries, but they're small sub-centimeters, they're not in the wrong place, et cetera, that there's really some reasonable data to follow them. So the danger, I would just add, I think, is when you open Pandora's box, you can't really close it. When you say the word cancer to someone, when you have data under the microscope, it does become harder. So I appreciate the 2011 approach. I think it's harder when you get to 2017 in this case, right?
Well, especially when the ultrasound reports are now calling it TIRADS and they're calling it suspicious, right? I mean, I've seen a bunch of these that they were fine watching for a long time. Nodule didn't change, but the report did. Janice, how do you navigate this? Obviously, I would assume most people like this are sent to you already with a biopsy, and they're probably sent to you to get surgery, right? So somebody walking into your office expecting total lobectomy, how do you breach this? Well, you might not necessarily need a surgery. How do you have that conversation? Oh, unmute there, Janice.
Yeah, those patients are, they take a long time in the clinic because now you have to sort of sit down and, as Erik said, it's Pandora's box. So you have to explain to them that, they could have had this for decades for all you know, and it could be safely followed. And you really have to get to know the patient and see how anxious they actually are about it. And so I make sure they understand they do have that option of active surveillance and what that would involve. But then when I see a patient that's very anxious about it, which doesn't sound like this patient, she was the opposite, then you have to say, okay, well, a thyroid lobectomy done safely. We then have eliminated having to worry about this. And I can't tell with the first meeting always how they are going to behave. And if they seem to think that they want to go for active surveillance, or at least that's a possibility, we have a program here. I send them to our endocrinologist. We have the same radiologist doing the follow-up ultrasound. So it's a true program. It's not just watch it come back in a couple of years with an ultrasound report. So you really do have to hold their hand.
Conversation. Zubair, Erik mentioned that part of the success of the Japanese program and other programs is proper patient selection. In a lot of the papers, it'll say if you have high-risk cytology or very worrisome cytology, we shouldn't watch. Does that mean anything to you? I mean, out of all these small nodules that get biopsied that are Bethesda 6, can you pick ones out that we should not follow just based on the cytology?
So, I mean, the Bethesda 6, the new version of the Bethesda classification says that, everything that you are going to do, besides calling it malignant, is going to be based upon your own experience, and you probably don't have to do it. Having said that, there are certain features that you can recognize in FNA that I have done in the past, where I will say, or some of my colleagues or I have seen reports from other institutions will say, there is some features which may be cellular features, plus a form of necrosis or mitosis that you can see in a good sample, and say that there are some features which may be seen in high-grade carcinomas. So I think those are the features you can pick up in these cases, but it is not something that somebody has. So I think it's all depends upon experience, as we see these. And I will say that if you give me 100 of these cases with these nodules, I may be able to say in one of them, but depends upon how good the sample is.
Gotcha. Before we move on to the next slide, Mark, in women of childbearing age, or maybe let's just say she told you that she wants to get pregnant over the next 6 months, year and a half. Does that influence what you tell her about active surveillance or watching versus surgery? How does that color your conversation, Mark?
Yeah, so I will advise a woman that there is a reasonably good chance that her nodule will show signs of enlargement during pregnancy. But I will usually tell them that that doesn't necessarily influence my decision here. I do think we know that in that age group, there's a much higher likelihood over the course of their lifetime that they will show progression, and it may be acute and then acutely change during pregnancy. But in and of itself, that really shouldn't influence their decision-making here.
Awesome. Okay, Dr. Pitoia, let's move ahead and show us how you're thinking about this.
So we usually, when we have a patient with a suspicious pattern, ultrasonographic suspicious pattern, we go to the fine needle aspiration. Here we explain the patient that we want to know exactly what we're talking about. But sometimes we let the patient choose, but we consider this an undercover active surveillance when we do not have the diagnosis, and we consider every single thing that we consider with the perspective and with the diagnostic of a papillary thyroid cancer active surveillance. So this is what we have been talking always with Professor Miyauchi, who he's prone to do fine needle aspiration to all patients to diagnose what we are talking about. I don't know whether your patients, Mike, have all the diagnosis, or you choose a group of patients with active surveillance with no diagnosis of a papillary thyroid cancer.
Yeah, we get most of, because I work at a cancer center, almost everybody wants a biopsy. I mean, they've had another cancer and that sort of stuff. So the vast majority of the ones I'm watching are, but when I get to meet them for the first time, I give them the option. I basically tell them the same thing. I think this is thyroid cancer. It's not going to make any difference to me if I biopsy it. So yeah, I agree. In fact, I think the real reason that active surveillance got in the 2015 guidelines is because the nodule people on the guidelines said you don't have to biopsy something less than a centimeter. And that by definition was active surveillance. To do active surveillance, you don't have to have a biopsy. So to be honest with you, in 2015, I thought it was a little early to put active surveillance in the guidelines. But because we made that decision not to biopsy small nodules, it made no sense to say, watch it if you don't biopsy a 7-millimeter nodule. But if you biopsy it, now you have to go to surgery, right? That's a logic flaw. So to my mind, that's why I was comfortable putting active surveillance as a start in the 2015. All right, let's see what happened to her.
Mike, let me just ask you a quick question. And for the panel, does the discussion change? Does the patient's mindset change if they actually have a diagnosis rather than a suspicion?
Yeah, so my bias is yes. And I so much so that when I'm not biopsying something, I really try to emphasize to them that I really think this is thyroid cancer. Like, I'll take you to dinner if this is not thyroid cancer. But I will tell you, when I don't biopsy them and then eventually end up doing a biopsy, they all seem to be surprised that it's really thyroid cancer. So there is definitely part of that. Erik, could you experience that?
Yeah, I mean, I agree with Mike completely, but I'll also add in, hey, what's in a name? What's in a term or a word? And the parallel I often draw is how nice of a job our field did in redefining low risk malignancy as something called NIFT-P, which no one can really understand what the acronym always means anyway, but it took away the word malignancy. And so when you say to someone, hey, you have a 5-millimeter, carcinoma, that's very different. And I draw that parallel. So I wanted to throw that in.
Absolutely. Yeah, so that's real. And I think somebody said you can't stop this train once you get it started. So I do think people perceive it differently, definite versus not there. Okay. So during pregnancy, what happened?
So the patient she didn't tell us that she was looking for pregnancy, but she got pregnant, and she came in May 2018 with 20 weeks of pregnancy, and there was a 3 millimeters growth in each diameter, which you can see here that the nodule went a bit, and the borders of the thyroid of the posterior left thyroid lobe. At that point, the patient wanted to continue, and we, of course, wanted to continue active surveillance. And I don't know whether you would have chosen a different option for this patient.
Janice, you see her 20 weeks. It's, Mark had already told her it may get a little bit bigger. It might not. 3 millimeters kind of on the borderline of is it a real change or not? But obviously the report says bigger. So now you've got a terrified patient on your hand. What do you tell her, Janice?
Yeah, I think, as Mark said, you have to say right from the beginning that there's a good chance that this is going to get bigger during pregnancy, but not necessarily mean that this is rapidly growing. So that's the dilemma. And again, it's the patient, right? Like how obsessed they are with this and concerned about it. Should you take it out because you've got two patients now, the fetus as well as the patient, and just put everybody at ease? Or can you calm this woman down to say, yes, we can continue to follow it. We do not think this is going to change your ultimate survival or prognosis if we wait till you have a healthy baby and then deal with it at that time. And again, you need a team taking care of the patient at that time, the endocrinologist as well as the surgeon on board.
Yeah, and the real truth, most of these patients that chose to watch during pregnancy or chose to watch, they don't get excited if they grow a little bit. They all make me do a confirmatory ultrasound to prove that it really grew before they do anything. So it's that mindset of minimalist. I do have a few like this that can't figure out if they're more afraid of surgery or more afraid of the cancer. They have a hard time, right? They're living on that edge, but most of them not. So I assume in her case, Fabian, the decision was pretty calm, that you said it grew a little bit, hang in there, we keep watching, and she was okay with that.
Yeah, sure. And another thing that is very important is what we read about pregnancy and active surveillance. We do not have a lot of data. We only have the Miyauchi data showing that there was probably in the first publication like a 50% of growth, and then a new publication showing an 8% of growth of the thyroid nodule. So probably this is they call a low percentage, but probably for 9 months this is a high percentage of growth of a thyroid nodule for active surveillance, because we see this 10% in 10 years. So 8% in 9 months probably is a large number.
That's the key. I've had 7 or 8 get pregnant, and most of them nothing happened. 1 or 2 of them got bigger, but it got bigger at exactly the same pace I would have expected. They were growing slowly before they got pregnant. So sometimes having something bigger 18 months later doesn't mean the pregnancy did anything. It was the natural history of the disease, right? Understanding that pace over time. The few that got bigger, and then they got stuck right there. They didn't continue to grow after pregnancy. All right, so let's keep going.
So this was what happened in this patient, because the thyroid nodule went back to the initial size, and it continued without changes until this time. So this patient have what we call a retrospective surveillance. What we think this is starting in 2011, these 6 years, and then now another years of follow-up, which gives 12 years of probably stability of this thyroid nodule. And the question is to you, Mike, because we think, when did this started? Because it has to arrive to these 7 or 8 millimeters. So and you presented very nice this tumor kinetics and active surveillance, and you can see here that probably most of the patients are in the first group. But my question is, couldn't we be losing a group of patients in the pattern 4 group that grow and then start being in the pattern 1?
So the answer is yes. So we put this a little bit in the paper because it was a little bit hard to think about. But if you think about everybody we watch, the average size is about 8 or 9 millimeters, right? They weren't born 8 or 9 millimeters. They had to grow up and plateau. And so we saw a few in that pattern 4 that were 4 or 5 millimeters. They grew up to 8 or 9 millimeters and they plateaued. So I think almost everybody in pattern 1, if I knew their history, they started in pattern 4 and then they flattened out. And that in fact is the natural history, not continued growth forever. So I agree totally, Fabian. That's the way I interpreted it. I couldn't say that like with enough data, but common sense tells me you get to pattern 1 by growing through pattern 4, just as part of the natural history. And then something else has to happen to get you out of pattern 1. Otherwise, you're stuck stable, and that's what happens most of the time.
Thank you. Well, I will show, just to finish the case, that we wanted to pressure for active surveillance a lot of patients, but in Argentina, it's very difficult. The acceptance is only 25% of our patients. It continued being the same in 2017 and in 2023. It is the same thing. It didn't change. And those patients who go immediate surgery do not go to lobectomy, and it's something that we are starting to move slowly here in Latin America, and especially in Argentina. And you can see here that most of our patients underwent total thyroidectomy. This was a prospective clinical trial, and we saw that a quarter of patients had adverse events, having vocal cord paralysis permanent in 2.2%, and permanent hypoparathyroidism in 5% of these patients. So this is something very important we need to focus and to change.
Zubair, let me go to you, then I'm going to come to Janice. What were you going to say, Zubair?
So I had a way, I mean, I'm always kind of puzzled by this as a pathologist when I'm looking at it at a surgical pathology specimen or a cytology. This growth stuff, you know, the tumor grew. And sometimes the growth is, and really we cannot tease out on radiology whether the growth is in that tumor mass, the flesh, tumor flesh, or it has gone under cystic change, or it is sclerosing, or is it infiltrating. And some of these tumors, like this case, which came back to the, the size decreased, I've seen those, they have little cystic spaces, and then they get sclerosed, and they are basically at the same site. Also, these smaller tumors, I think ultrasound does measure them a little higher, because when you see them grossly, and yes, nothing is perfect science because you're doing the eye, it's always smaller. So I'm always puzzled on cytology as well as on histology. When I see these tumors, they say tumor was growing, and then you look at it, it's not infiltrating, it's that small PTC. I don't use the term micro, and and they have little sclerosis, little cystic stuff, and they say, well, there was a growth. So I don't know how good radiology is in really assessing it, because the way the patients are followed. So I always get a little puzzled by looking at them and saying, so I just wanted to know what your thoughts were, or there were any.
Yeah, I mean, I'll go first. Yeah, so I basically tell patients I think the volume changed. I don't know whether that you had more thyroid cancer cells. You definitely see some of that little cystic stuff. And there's also plus or minus 3 millimeter measurement variation that's not really real. So I agree with you. I don't think it necessarily means the tumor mass is getting bigger every time. But in the little small ones, we generally don't see a lot of cystic spaces. Now, it may just be too small for us to see, right, on the ultrasound. Yeah, so I'm with you. Janice, talk to me a little bit about, sometimes I get the argument in active surveillance that it should only be done if you're in a high volume center and you have excellent surgeons that can rescue and that sort of stuff. But as Fabian showed here, this is active surveillance. And if your surgery complications are going to be a little bit higher than maybe what you had in a really experienced surgeon, how do you make that balance between the risk of watching a small thyroid cancer, maybe 1, 1.2, 1.4, versus the risk of somebody getting a total thyroidectomy and those complications? Because most people in the world getting surgery aren't being operated on by highly experienced surgeons, right? How do you think of that?
Yeah, I think that's a good point, and that's probably why active surveillance is becoming more part of how we deal with thyroid cancer, recognizing that there's a significant number of patients with this low risk papillary thyroid cancer that we're causing more harm than good by being aggressive surgically, because we haven't really changed the outcome. And that's a big, swing of the pendulum from everybody with anything over a centimeter in size needed a total thyroidectomy and radioactive iodine. When we started realizing they don't need radioactive iodine, we could do less surgery. And now we're even going even farther. Do we need to do surgery at all? And I really do think it's partly driven because we're looking at our true outcomes. Post-operative hypoparathyroidism and nerve injury are actually being documented, and surgeons are now a little bit more aware. The endocrinologists may have been aware long before we were, but I think as surgeons, we're being more dogmatic about really knowing what our complications are and looking at adjuncts that are going to help us decrease that rate of hypoparathyroidism with intraoperative localization of parathyroids, decrease our nerve injury rate with the use of the nerve monitor. Because these are serious complications, and we need to, as surgeons, just do better.
Mark, last comments on this before we go to the next case?
No, I guess it's certainly, I think one of the fundamentals here, as Fabian mentioned, is the fact that there is a huge difference between the risk profile of a total versus a lobectomy. And to be fair, one needs to do the proper comparison here of what those adverse events were. But it is what it is in terms of where you're practicing and what surgeons and patients want to do. So that would be my only comment here.
Yeah, I mean, it's a risk-benefit ratio that's going to vary depending on where you practice and where you work and patients, and we just have to be aware of that. All right, Dr. Pitoia, let's do the next sort of challenging one, these thyroid globulin antibodies that don't go away, and how do we deal with those?
Okay, this is a female patient, 29 years old, at her first consultation in 2017 with a history of Hashimoto thyroiditis under treatment with levothyroxine. Since 2015, she had at that time a thyroid nodule of 7 millimeters, which had not been addressed or evaluated. So she came with a thyroid nodule measuring the same pattern and size observed in 2015, but at this time, a fine needle aspiration biopsy was done in another center showing Bethesda Category papillary thyroid cancer. You can see here the thyroid nodule, very posterior in the left lobe.
Erik, assuming this patient doesn't want to watch, she's going to have surgery. She's just taking it totally out of your hands. That history of Hashimoto's thyroiditis, does that color you sort of lobe versus total, or does that enter into your decision-making process at all?
I guess the way I think of it is we've really shifted as a field over the last 20 years. I don't know if anyone would have recommended a near total, from the start for something sub-centimeter, but I think we were taking out much more of the thyroid 20 years ago. And certainly now the standard is as kind of limited as you can be, I would argue. So I don't think the Hashimoto sways me to want to take out more tissue necessarily.
Janice, when we send you somebody for surgery that has like all this Hashimoto's on the ultrasound, is it a more difficult surgery? I mean, I hear you guys talk about sometimes it's sort of a little sticky, or it never pops up in the op note. But does that, because what I'm worried about is if we do a total, and are we getting like more complications because it's hash than if it's not, or am I just dreaming stuff up?
No, I hate Hashimoto's disease. I really, I find that it can be harder to take out. There is a lot more sort of inflammation. The other thing that throws you off is there's all these lymph nodes, and you're sort of looking at them. Are they positive? Is this, and both preoperatively on your ultrasound, but then at the time of surgery, I do find it is a much more difficult operation for the majority of patients, and you can't always predict that. And it's just harder. The gland is harder. It's harder to roll and to take it off the trachea it just doesn't come out the same way. So personally, I'm not keen on operating on Hashimoto's because it's a tough operation. I don't know if Mark finds the same thing.
Mark?
Yeah, no, I agree with everything that Janice said. I think the one thing that patients are aware of is that their lifetime risk of requiring thyroid supplementation is significantly higher, and therefore the if they do require it, and often patients are educated and do come in saying, well, why don't you just take the whole thing out, because I'm going to need thyroid medicine anyway. And so you kind of have to walk them back from that and explain some of the issues that that Janice just mentioned.
Yeah, I think it's important because we'll have to, as endocrinologists, we go, you're going to end up on thyroid hormone pills anyway, just get the whole thing out without sort of thinking. Again, we don't always have the #1 surgeon in the world doing our patient. You know, are we exposing the patient to more risk by taking that other side out that's not necessary? All right, Fabian, let's go through this one. Tell me what happened to this young lady.
So this patient was really very maximalist. She underwent a total thyroidectomy. At the very initial moment, she chose to undergo a total thyroidectomy, and the pathology shows in the left lobe a papillary thyroid microcarcinoma of 6 per 5 millimeters, and another minimal focus in the contralateral lobe of 2 millimeters. So she had a multifocal papillary thyroid cancer. Since then, biannual follow-up had been conducted with laboratory tests and ultrasounds, and she had additionally an incidental 3 millimeter thyroid cell duct cyst found, always undetectable TG levels with TSH between 0.8 and 1.5 under levothyroxine with a stable dose of 88 millicentigrams per day. And here you can observe the first year evolution of the TG antibodies, which remained pretty stable at that time. The patient was, I remind you that the patient was very maximalist. I tried to convince her to wait for RAI and remnant ablation. We were not going to do anything. But at that time, it became very difficult to keep her.
So Erik,
without.
Erik, what do you deal with it? So we're zero surprised she's got antibodies. She had hash to begin with. We knew about it. What are your expectations over that first year? How do you sort of set, you know, what may happen to this young lady?
With regards to the antibodies or just total prognosis?
Both. Just do both.
You know, I'll see her back in the office and she'll say, oh my goodness, I'm glad I took that other half out. Look, there's a 2 millimeter thing. And I'll say, I think it's great. You know, I think it's great. You heard the pros and cons, and I'm really happy you got it out. So that's what I usually will say. And I'll say, typically, I think we're done. I don't think you necessarily need to do a whole lot more. We certainly will monitor now with the whole gland out. You can use thyroglobulin. Of course, here you have antibodies. So what do I think about antibodies? They get in the way, you know, is the starting point. But so a couple of thoughts on it. One is increasingly in the US, but not necessarily everywhere, we will reflex the basic thyroglobulin antibody ELISA over to a mass spec analysis where you can get a little bit more guidance. And the sensitivity of thyroglobulin mass spec has, in my at least lab, has gone from 0.5 as lower limit to 0.2. I think it's a little bit not as sensitive, but it still can be reassuring, I guess is the way I think of it. My take on antibodies in general is if they decrease and go away, that's actually really good news and very supportive. If they kind of stay there, but kind of go up and down, but no real pattern, I also don't make much of it. I just pursue ultrasound if I needed to, more of a follow-up tool. If they go up, you know, there's been some data to suggest that there could be some progression of disease. It makes it more difficult, I think.
So Monica, I'm not really good with geography, but maybe Australia is closer to Buenos Aires than New York. I'm not really sure. But if she comes down,
I don't think so.
If you don't think so,
no, I don't think so either.
Australia is a long way from everywhere. Okay, let's
That's
just
right. Last stop
admit.
before the South Pole. Yeah.
Any role for radioactive iodine here in terms of? Yeah, I mean, we got a low risk patient, but you know, you're going to get involved in this, Monica. So how do you sort of think about this?
Well, there is a theory that if you get rid of any residual normal functioning thyroid tissue, then the antibody levels would drop. So in a situation like this, for me, this would be the only case where I would consider giving 30 millicurie dose to ablate any normal residual thyroid tissue. And often, once you give that, the antibody levels do drop.
And the risk
Yeah.
Risk of side effects and that sort of stuff from 30 versus 100 or 150 administered activity, Monica?
I think it's less. I think it's definitely less because, you know, it's a kind of dose we would, similar to what we would give for Graves' disease, and we don't have the problem with sialadenitis with that kind of a dose. Yeah.
And plus you get a post-therapy scan, so maybe she'd find that reassuring as well. All right, so Dr. Pitoia, I assume she wouldn't leave your office without a small dose of radioactive iodine?
Yeah, additionally, she worked for the the pharmaceutical industry, and she worked with thyroid. She was pretty working with thyrogens, so she was there was a lot of bias there, and she wanted a RAI and remnant ablation, and we tried to think about the dose, 30 millicuries. We would have chosen 30 millicuries, but we explained that if we want to do some adjuvant therapy for any additional thing that we are not seeing, probably we could increase the dose. And she received 75 millicuries after recombinant human TSH, and both the whole body scan showed the uptake in the thyroglossal duct cyst.
I agree. So that kind of dose is for tumor eradication as well as normal thyroid tissue.
Mm-hmm.
Yeah,
and not unreasonable. We should still have fairly low side effects from 75, right? Most people tolerate that well without much salivary gland tissue.
Yeah.
Okay. All right.
Mike, can I just point out a point for the surgeons that may be on the call? And you know, the pyramidal lobe is, I call, the forgotten lobe. And it's very important if you truly are doing a total thyroidectomy, but even if you're doing a lobectomy, that the pyramidal lobe should always be taken all the way up to the hyoid bone. For this reason, you've got a thyroglossal duct cyst. That should have come out with the original operation. And surgeons sometimes forget to follow that track all the way up. But the pyramidal lobe should come out with a lobectomy and then therefore from a total thyroidectomy, so it isn't part of this spectrum.
And the pyramidal lobe, like connects to the thyroid, or sometimes you get like a little thin fibrous tissue. How do you find it, Janice?
Yeah. Well, the pyramidal lobe can be a true lobe that you can see and connects, and most people, when they see that, will go to take it. But I find that a lot of the times it's just, you may just see you may not see it as a predominant connection to the isthmus until you track all the way towards the hyoid bone, and you have to clear out that central compartment all the way up to the hyoid and not come across it at the isthmus.
It doesn't feel like to me that's mostly done, because on our spec CTs, we will almost invariably see a little bit of pyramidal lobe there. So that's, I mean, it's a good comment.
I'll talk to Baloch later and tell him how to do it.
Don't get me in trouble. He listens to these, and I have to go to clinic with him in a few minutes. So I retract that. Never on Dr. Shaha's cases. Maybe they're Mark's cases I'm remembering. Okay, take us to a little bit more here, Fabian. So I want to get to the third case too.
So here we observe that the TG antibodies decrease in the next 4 years, probably to half, but the patient was very anxious still because of the persistence of the TG antibodies, and she read that this was not normal after some 3 or 4 years after initial treatment. And so a PET CT scan was done just to make her calmer, and it didn't show anything, and the TG antibodies continue being the same at this time. And the question is why we have this long persistence, and we tried to do it in our population to understand. First, we wanted to compare about the patient who received remnant ablation, no remnant ablation, and comparing among all the risk of recurrence. There was no differences in our two population with negative or positive antibodies to CDs. And what we saw is that the structural incomplete response was the same according to the risk of recurrence, independently of TG antibody positivity or negativity. And also we saw a faster negativization of TG antibodies in those patients who do not receive remnant ablation compared to those patients who receive remnant ablation, 11 versus 16 months. And this group of patients with long-term persistence we try to figure out what happened with those patients. Only 10% have structural incomplete response, 30% negative these antibodies, and 60%, which becomes around 17% of our population, have this same situation with follows up of around 10 years, median follow-up, and nothing found. These patients before received new radioiodine doses, new PET-CT scan during their follow-up, even when we have these stable but high, like 2011, 1,000 millunits per liter of antibodies. So this is a group of patients we see every day, and we are always worried and trying to understand. Of course, we look at the risk of recurrence, but we are trying to understand exactly what do these antibodies mean? Why do they not get negative during the long-term follow-up?
Yeah, I wish I knew the answer to that. These patients drive me crazy. Your number feels very similar to what ours is. And as Erik was saying, typically they go down about 50% that first year, and then they'll often trail down. But some of these guys just stay there. Anecdotally, it feels like some of these guys have huge family histories of Hashimoto's in their family, their mom, their dad, their dog, their cat, everybody has it. So I tell them this is just their immune system. And after 2 or 3 years, I try to get out of tons of imaging and studying, because you just find lots of false positives, right? The PET scan was reassuring, but we're really glad we didn't find a false positive in an axilla or a neck or something that we had to chase, right? So these are a challenge. Erik, how do you deal with these down the road?
I just wanted to call out first what I think Fabian showed really nicely, which is the wide discrepancy between two different manufacturers and also how the appearance of antibodies can come forth, which is way different than like differences in TSH normal ranges or something. And in the era of open records to your patients, I think I spend more time sometimes on that, which is it did go from 500 to 60, and you have to really explain the analytic issue, which it's hard to explain, to be honest. So I wanted to call that out because I've also myself, just sharing my own experience, been tripped up where I actually didn't realize it was a different assay and made some assumptions. So worth sharing.
Yeah, absolutely, without a doubt. But I think the take-home point on that one is not uncommon to have persistent, stable-ish antibodies. Radioactive iodine isn't going to magically make them go away. And the imaging needs to be sort of addressed to pretest probability. So she was low risk to begin with, and time of follow-up. So after 5 or 10 years, I actually moved these guys out of the indeterminate category and call them excellent. I just say it's been stable for so long because their risk of recurrence is so low. But it's hard because you feel like you're flying blind without being able to measure that thyroid globulin. Yeah. So great case and no great answers there. All right, let's look at one I want Dr. Rossleigh to feel like she has a job. So many of these tumor boards, we're constantly telling her radioactive iodine doesn't work. So we're throwing her a bone here. So apparently we're going to show her something that works. Dr. Pitoia.
So this is a female patient of 24 years old with a personal history of systemic lupus erythematosus in 2013 with renal involvement, ischemic stroke in August 2015, deep vein thrombosis in March 2016. With a medication history, you can read here a lot of medication to treat all the conditions this patient had. So in May 2016, their thyroid ultrasound showed a hypoechoic and heterogeneous solid nodule measuring 10 per 11 per 13 millimeters with irregular borders. At that time, a fine needle aspiration biopsy done in another center showed that she has a Bethesda Category II. Here you have the description of this Bethesda II. Probably Dr. Baloch want to make some comment on this, because it was informed as a Bethesda Category II.
Zubair? Then when we get a Bethesda 2, that's we're comfortable with that, right?
Yes, the malignancy risk is basically between 0 and 3%. And I think it's mostly related to not just the experience of the pathologist reading it, but it's also like what was biopsied. But I think everything matters in these senses. So, the benign diagnosis does not, and I will say 90% of the time is benign, but, it has to be in the context of what you are looking at on ultrasound also.
And Erik, follow that up with that. Occasionally you get this benign biopsy, but the ultrasound screaming on cancer. How do you sort of balance that?
Yeah, I think there are some other good follow-up sonographic data that when you have a concern based on sonographic patterns or a high TIRAD score, that repeating the biopsy and follow-up and having a shorter interval follow-up is important because exactly as Zubair said, everything carries a confidence interval, right? And nothing is perfect. So the value, I think, of a workup in this field and every field probably is how you integrate all your pieces together.
Right, and negative predictive value has to be overlaid on pretest probability, right? If this is a really high risk nodule, it's probably not 0 to 2% with the cytology in isolation, right? All right, so Dr. Pitoia, where do we go?
So in 2019, we saw her for the first time, and the thyroid nodule grew up, and it was 17 for 18 for 16 millimeters, and a second final aspiration showed a follicular neoplasm, a Bethesda 4 category, with the thyroid nodule, which was really very posterior in the left lobe. All the three nodules I showed today were in the left lobe, very posterior. Coincidence. And at that time, lobectomy was indicated. At this time, we wanted a lobectomy for this patient, but as always happens here, the surgeons and the patient wanted a total thyroidectomy. And luckily, because she had a papillary thyroid cancer, 1.5/1/3, with the presence of 4 foci of vascular invasion with no extrathyroidal extension. And the pathological diagnosis at that time was a follicular variant of papillary thyroid carcinoma, stage 1 from the TNM, and an intermediate to high risk because of these 4 foci of vascular invasion.
So Monica, I'm going to make up a number. Let's say 6 weeks after surgery, her thyroid globulin is 30 on thyroid hormone therapy. So we're thinking about radioactive iodine. She had lupus. She's got some renal issues involved. You're worried that she might have distant mets. Think out loud a little bit about sort of how you're going to pick your administered activity and how those factors would sort of favor into sort of how you're going to get her ready for radioactive iodine.
Well, it's important that her renal function is normal. So if there is impairment in renal function, you certainly have to reduce the dose. That would be the main issue. But so there's no histological description of any lymph node involvement in this. So we don't know if there were lymph nodes, if they took any out of the central neck. But on just this pathology, I would have probably given a standard dose of 100 millicurie. Gotcha. Because of the 4 foci vascular invasion, as long as she's not anemic and her renal function's normal.
Right. And even in the absence of the TG number I gave you, just adjuvant therapy alone with a young person,
yeah,
4 foci of vascular invasion. All right. And Dr. Pitoia, what happened? What did you guys do?
We heard Monica advice, and we administered 100 millicuries, and it was after thyroid hormone withdrawal with a stimulated TG level of 174 nanograms per ml. With negative antibody, and this was the post-dose whole body scan with the CT scan showing no relevant findings.
All right, Monica, help me understand this scan. So the CT scan shows no nodules we can see, and we've got this diffuse uptake. How do you interpret that?
Well, the way I interpret it is this is like a pediatric thyroid cancer in a young adult, and this is most likely due to diffuse lymphangitis in both lungs. And this kind of scan appearance, generally we can fix them. They get a good response to radioactive iodine.
Yeah. And Zubair, any idea? I mean, most of these don't get biopsied, and you probably don't see them underneath the microscope. But in that pediatric thyroid cancer, what do these look like underneath the microscope?
They follow the same rules, so they look the same. But I will say that, by looking at the description, it's a small tumor, right? To begin with, it's not a huge tumor with 4 foci of vascular invasion. So we know, from the dumbest pathology view that this is an aggressive tumor. And in pediatric age group, I have seen these fusion-associated carcinomas, which tend to be follicular variant, and then sometimes they have a lot of colloid in them. And that's why we had a case in-house that initially we thought it's an ectopic thyroid tissue or it's benign thyroid tissue because it has the best colloid you can see in a benign nodule. So, and I've seen these in pediatric age group. They tend to be NTRK associated tumors, some of them, and they can really fool you because even their multifocality, you may not, but they have a very high incidence of vascular invasion and these distant metastases. So for me, from a size of the tumor, having those 4 foci, sometimes you have the 7 centimeters tumor and you're looking for vascular invasion and you're not going to find it. So for me, this, by just looking at the pathology, reading it, it sounds like a very, it's going to be an aggressive tumor.
That makes sense. All right, Erik, this is always one that typically you'd have been able to warn the patient because their post-op thyroglobulin is usually higher than we anticipate. So we usually are at least able to say their stuff. What do you tell her and mom about prognosis and outcome, and where are you now?
Yeah, I mean, you have this complexity that these are the ones that keep you up at night. Like, oh my gosh, am I missing these things? And many of the low risk issues we would be so conservative increasingly on, right? So, I mean, I just want to share the anxiety I have talking even about this case. But the bizarreness yet wonderful nature of this is the factor of age, right? That we've long known as it relates to thyroid cancer. And while we used a number of 45 and now 55 and whatnot, the reality is the iodine responsiveness, and I always kind of harken back that you can't really be beyond a stage 2. Why is that? If you're a young person, it's because their response to therapy is so good. So they certainly get close follow-up. I will consider other radioiodine at times, but I sure like to see the effectiveness of this first dose. So I will walk it out as far as I see thyroglobulin going down, no anatomic growth, and at times it can go on for years, right, before you need a second dose.
Yeah, Monica, because my approach on that has changed. And when I trained back in the 90s, we would bring these guys back in 6 months and rescan and maybe retreat. And then by the early 2000s, we were saying, well, just watch that thyroglobulin. I've got some of these I've watched for 10 or 15 years now, and I haven't repeated their dosing. So is there a point that I should be repeating dosing? I mean, going for the kill, or do we just watch the thyroglobulins? I know there's no data, but you've been doing this for a couple of years. What do you think about that?
Well, we, as you say, when I first started managing thyroid cancer, we would do 6 monthly iodine scans for, and then for the first year, and then we would torture the patients because in those days we didn't have thyrogen, so they were hypothyroid for their original treatment. They finally got euthyroid, and then we withdrew the thyroid hormone again at 6 months, and then we'd repeat it 6 months later, and then again at a year. So we're not doing that now. We're just following with neck ultrasound and thyroglobulin, and I think it's reasonable to do that in this case.
Yeah. And Fabian, how are you following these guys now? It's the best case, right? It's a very RAI avid. CT scans look great. You're not worried about out of control stuff. How do you follow these now, Fabian?
We usually follow the response to treatment to define the next. So if we have undetectable thyroglobulin or a very low and stable thyroglobulin, probably we do not administer a new iodine dose, and we try to figure out how the outcome of the thyroglobulin moves, and if it is increasing, probably we repeat a new iodine of 100 millicuries. And we have to understand that here, for most of our patient, we have to do thyroid hormone withdrawal. This is a very different situation to what we have in the first world, when you can use thyrogen everywhere with all the patients. Here, we need to know if the patient have the reimbursement of thyrogen, and for most of our patients in the hospital, we have to choose thyroid hormone withdrawal.
Monica, I got an email a couple of weeks ago about a case similar to this. Same thing, follicular variant, lots of vascular invasion, but she had positive antibodies. So the TG wasn't high, and they gave her 100 millicuries after thyrogen and saw this exact same scan. In Fabian's case, this was hypothyroid withdrawal. But if you get this scan after thyrogen, does that change how you think about it? Effectiveness, bother you one way or the other?
Well, it does worry me because I think the data suggests if you've got metastatic disease that it is better to do thyroid hormone withdrawal, because with thyrogen, the retention in the tumor is not as prolonged. Yeah.
But you would worry and not do anything different. You wouldn't bring her back for another dose immediately. You would just worry more and watch her?
Well, I think you're monitoring with her thyroglobulin. Well, what do her antibodies do after the dose? I know Fabian's just said that they don't always disappear, but often they do. And I think if they have got persistent antibodies, you would have to repeat the scan.
Yeah.
Because you can't rely on the thyroglobulin.
Yeah. And I think
Yeah.
for the ones listening, part of the reason we're so laid back is we know that CT scan doesn't show any big disease, right? If we were dealing with big lumps or big bumps, we might be doing some more scanning. Erik?
I know time is short, but I want to throw in the evergreen question to you, Mike, which is the lobectomy here was recommended. I think many of us would have led with that. And the question always is, should we have used thyroglobulin in that setting routinely after lobectomy to pick up the really rare distant disease, but you'd expect thyroglobulin to be 100 or 1,000 or whatever? Because I know there's data also out there that thyroglobulin is not useful after lobectomy.
Yeah, so I think the ATA guidelines are going to change on this coming up. They're probably going to say don't follow thyroglobulins over time because it's neither sensitive or specific after lobectomy. I still check 6 weeks after surgery looking for exactly this. When you do a lobectomy and there's totally no changes in the other lobe, that thyroglobulin is usually less than 10.
Right.
And so if it comes back 30, 40, 50. So I think the idea that you can't use thyroglobulin is probably not correct. You have to interpret the thyroglobulin in light of what you see on the other side, right? If there's some nodules on the other side, maybe you tolerate 30 or 40. But in somebody like this, a young person, that thyroglobulin ought to be less than 10 after lobectomy. So I personally am still going to do at least one after surgery. And to be honest with you, I'll probably do one every few years anyway, looking for that 1 in a million. Yep. Perfect. All right, Fabian, show me what happened to this case, and then we'll finish up here.
So here we can see that in 2020, she had a thyroglobulin in 2019 with an insufficient dose of levothyroxine of 58. It decreased, and then it decreased by the beginning of the pandemic to 2, and then with a suppressive PSA to 0.1. At that point, we wanted to do a new RAI dose. When she had the 2, we wanted to do that. Pandemic helped us not to do anything. And so the patient remains until this moment with an excellent response under TSH, not suppressive, but a TSH less than 1 with an annual neck ultrasound with no relevant findings.
And to be fair, you can see why Monica and I would retreat every 6 months, because if we would have given her another dose in November 2019, our interpretation would have been it worked. Thyroglobulin went down again, right? So that's why it was so hard to get out of that pattern, that this was the natural history of that first dose radioactive iodine. And I think we really learned this from Christoph Reiners in the kids, the Chernobyl kids that had distant metastasis, that Dr. Reiners and his group in Germany would treat the Belarusian kids with radioactive iodine, and they would have retreated them year after year, but because of politics, the kids couldn't come back, but they would send them their blood. And it was Christoph, I think, for the first time about 20 years ago that showed us, surprisingly, that number kept going down. And he was just honest enough to say, if they had come back to Germany, we would have retreated them, and showed that data, and I think made us learn from there. Finish up here for me, Erik. So you've got this sort of general thing of high-risk patient to begin with, and now an excellent response. When do I do a CT scan of the chest? When do I do another radioactive iodine? Do I rely totally on the thyroglobulin? How do we sort of follow her over time?
Yeah, I mean, my approach is both a little bit biochemical follow-up, thyroglobulin, and then anatomic CTs, knowing that I always tend to favor, though, the biochemical. We know that's more sensitive. And I kind of just start to increase my intervals the farther I go. But I'm very honest with the patient. When someone's kind of a 1 in 1,000, they deserve kind of a unique follow-up, in my opinion. So it's hard to let them go. But honestly, with continued good 6-month follow-ups, I'll do 9 months. And then maybe way down the road, I'll do once a year even, kind of thing.
Yeah, I mean, I think you have to.
I'll add, the biggest thing I'm reluctant to let go of is TSH suppression to some degree. I just don't want them to get up to 3 to 4 to 5 or something for whatever reason without data on that.
Great, but avoiding stimulation, right? That sounds reasonable. Fabian, I'll make a couple comments. Jump to your last slide so I can see all your teammates and everybody. So yeah, I think on cases like that, following over time, because CT scans and that sort of stuff, you may be finding more false positives than real disease because of the likelihood of finding the information there. All right, Dr. Pitoia, show me your acknowledgement slides. Take me to the end because we're about to stop in 15 seconds.
So no, I was just trying to tell, but this will be long to say the dynamic risk assessment and how these help us to move. But then understanding that the high risk patient usually do not have an excellent response to treatment, and if we have to look at our population of high risk patient and the metastatic disease, we have only 1% of these patients with distant metastatic disease having undetectable thyroglobulin level, which is really very, very infrequent to find. And we know that for the high-risk patient, the risk of a structural incomplete response is a bit higher for those patients who have an excellent response with another risk of recurrence, probably near 10 or 14%. And we need to continue searching very, very closely for these patients.